thank you for sticking with us. I know it's after quitting time per se, but we've got a few minutes for questions. Would love to answer them, and I know each of us would be happy to catch up later as well if we don't get a chance to now. Well, I'd be happy to take the first one, I guess, as chair's prerogative. So, I mean, to me, one of the things that really, I think, shines through with regard to these harm reduction studies and the economic evaluation alongside of them is the dissemination piece. And, you know, I think it's one of those things that's kind of easier said than done oftentimes to get these messages across to decision makers. And so I'm curious really from each of you if, you know, hearing insights I guess you have. So for example, like Zarina, you know, dealing with, you talked about the tendency even for oftentimes studies to miss some of these costs. And if there was any kind of sticker shock, I guess, when you presented the findings and, you know, how you dealt with that or the tools you gave the Department of Health to, I guess, I don't know, to utilize those findings. In Sybil, I'm curious, you know, about any kind of differences that you have encountered or might encounter with regard to the different types of clinics, even the municipality and the provincial, and Zhao, with regard to the decision analytic modeling. I mean, I think it's kind of one of those things that can be really tough to wrap your mind around if you're not familiar with everything that goes into that and the outputs and everything, and so strategies for that. So
sure, I could start. The dissemination part is really quite a lot of time and effort. You know, we spent a lot of time meeting with the health department to talk through those results with a bunch of different types of people within the health department, communicating, you know, why, you know, there was these different types of costs. And I think talking about strategies to improve efficiency was there, but also not, you know, in a way that the health department could support the harm reduction programs. And even for the harm reduction programs, I didn't mention it, but we created a cost tool for each of the programs that we had interviewed that actually calculates all of the cost and budget that they would need to sustain that program. And if they change something, you know, how would that change their costs? And so for that to be sort of a helpful tool for them to use when they're looking for grants or looking for additional budget. So I think, you know, when you're working with harm reduction programs, I think it's really important to seek a way to give back something to the programs. And then working with the health departments, it's really important, I think, also to communicate what the harm reduction programs wish they could communicate to the health departments about their needs, and be that person to kind of communicate between these two groups. And I think that was a lot of work, but I think it was very useful and I think important for us to do when we do this type of work. Sure. Yeah.
Is there any kind of like mandate for like the city council or the Department of Health to use that data as it comes in, or you know, like where does it go once it kind of hits their shelves?
Yeah, you know, it's a really good question. It really depends on the project, and you know, for the overdose prevention centers, that was something they were seeking to do. It was a very short turnaround time, 6-8 months, and then they had to get a report in front of city council on all of these, you know, different studies that they had done. And so, for instance, for that, it went to city council. Someone was looking it over. We had a deadline. For the other study, that was something that had no timeline per se, and, you know, I think as researchers, we have to try to find a way to make it a priority to have those discussions, because if you don't, it can just sit on someone's desk for a while. And so I think that piece is really important.
Sybil, really fast.
Okay. So to answer your question, Sean, there's a lot of difference between the Western Cape Province Clinic and the City of Cape Town Clinic. First of all, the Province Clinic, when we presented them with some of the data and during the time of interviews, they informed us that they were not aware that substance use is one of the key factors that contribute to ART non-adherence. So at that point, they had already started seeing a benefit of implementing the intervention at their facility, and therefore it would mean that there's more appetite at the Western Cape province for the intervention. And compared to the city of Cape Town, they already have a lot of substance use treatment programs across the city. And for them, the intervention means a lot, but it would be in addition to something that they already have. So the implementation costs of this intervention for the city of Cape Town would be completely different compared to the Western Cape province, who would obviously be starting from scratch because they don't have any co-located substance use treatment services in their facilities.
Cool, thank you. Zhao?
I'm just going to share some experience from the perspective of mothers. So what I found is that in a lot of cases, a lot of good modeling studies are just for the publication purposes, where they're never being applied in policy. The biggest issue is that the modelers do not communicate enough with the public health. So we found it's most important, when we conceptualize our studies, we kind of collaborate with the health departments for us to form the meaningful study questions that can address their priorities so that the priorities can be aligned. And we found it's most helpful. And also, as Serena said, communication is very important. So the most useful tool we found in communicating with the health departments is the dashboard that I just shown. However, that is not enough. So that's why in our new phase, we want to develop a series of decision support tools, not just this dashboard. We also want to build our Shiny app so that the decision makers could play with the tool by try different inputs and see the outputs so that they can make better sense of the model itself without have to code the model. So I think those different tools will be important, for not just for decision making, but for future use.
Thank you. And I know we have a couple out here. I think the gentleman in the red shirt was first. Yeah.
My name is Kwame from Tanzania Network of People with Drugs. My first question was, I wanted to know to what extent you're involved or engaged the community of people who are using drugs or engaged with drugs. And the second one, I know that we are looking to the consideration of economic evaluation of harm reduction programs, reading between data and policies, but my concern is that when we talk of harm reduction, it's not about all the health issues, but also improving the lives of people who are injecting or using drugs. Should you go beyond seeing the improvement of the lives of the people who are injecting or using drugs and whatever study we did? It's a general question for you. Thank you.
Sure.
Okay. So from the South African perspective, and specifically the clinical trial that I presented on, we do include people who use substances, and they are part of what we call a community advisory board, where that we usually sit with community advisory boards before we go into healthcare facilities to implement an intervention that's going to be tested. And they share their views and what they believe would be more beneficial to their community. And secondly, in our pilot, which we did first before the clinical trial, we found that people who use substances find it more easy and open up to peer counselors. So this intervention specifically, the people that deliver it are peer interventionists, and this decision was informed by the feedback that we received from people in the community advisory board, and those are people who use substances. So they were very much involved in designing and deciding on who delivers this intervention. Secondly, we don't make mention of people who inject drugs because these are not commonly used substances in this community, specifically in Khayelitsha. So the main methods of use are obviously alcohol consumption and cannabis, Mendrax, and methamphetamines. So that's why you don't see a lot of that being reported for this trial, specifically in Khayelitsha in South Africa. Thank you.
And I would just say that, most of our teams, when we're working on the economic piece, is really interdisciplinary teams. And, oftentimes that does involve, talking to patients or, people who use drugs and their experience with, say, for instance, it's a trial that we're have an economic analysis beside. And we're involved with hearing all of that and understanding that to inform the work that we are doing. So, that piece is important. I think you make a really strong point that, we need to center our work on those people who are at the end of those interventions and making sure that it's serving their needs.
Great. All right. One more question.
Yeah, a really quick one to Simon from Sweden. Thank you very much. I'm interested if you have any comment on, or maybe we can discuss later, about the economic evaluation of harm reduction programs when they are implemented, like follow-up of the results. For instance, you show us that you could lower the overdose deaths by approximately 10% by distributing 10,000 naloxone kits. So it would be great to have some kind of Power BI or whatever easy program for the harm reduction staff, because they are overworked and everything, to just enter all the figures of what they are seeing in their practice, sort of longitudinally, to better improve your model, and also some possibility to enter other factors, because you still have 90% of the overdoses or deaths left, so that could not be affected by more naloxone probably. But maybe the staff in the harm reduction unit knows the people, or they hear from a friend of the one who died last week that it was because he lived alone, it was because this and this, and then you can enter these figures and evaluate. I don't know. It was just an idea I got now. But no, time is...
Yeah, but this is very good advice. You actually, so in our Profound 2.0, we are considering a broader stakeholders in our project, in which, not beyond just the health departments, we're also, connecting, trying to getting people from like community program together so that we can get more insights of what are driving the increase in the of those events. In the meanwhile, we are constantly updating our model to kind of account for those time varying factors into our model to make it more credible and more relevant to timely decision making.
Great. Well, I don't want to be the one that keeps you from the reception, so I want to say thank you again to all my wonderful colleagues, and thank you for attending, and as I mentioned, please do follow up with us if you have additional questions.